We have 3 different topics today, and they basically complement the talks we had last week. So we started off with the importance of outcomes on Monday of last week. Then Chris gave what I thought was a very interesting view on the way he treats neck patients, the problem of, and then also the proprioceptive and neuromuscular control issues that are known with neck patients, how he assesses those and treats those. And today we're going to connect all that together to what the NeckCare solution is, what the Neck Smart system is. And for that we have 3 different sections. The first one, I will tell you a little bit about how this innovative technology complements the treatment plans that you are used to provide your patients with, potentially providing a little bit more of an objectivity to it, and potentially also including your patient more personally into the treatment with some homework, if you will, through telemetry and telemedicine. Then Maki will tell a little bit more about the technology itself. What is it? How does it work? How reliable is it? And what tests does it provide? And then we will basically go and conclude everything by giving you a bit of a clinical interpretation of the outcomes that are provided by the system. So like last time, we'll just save questions until the end, but feel free to, if ever there is a question, write a quick personal notice to Maki, and we will recap on all of those questions by the end of the session today. So first part is about taking a look at how this technology can actually complement your treatment as you're used to providing it. And obviously NeckCare, Neck Smart, the names say it themselves. It is about cervical spine. It is about what is proven to be the 4th leading cause of disability, and that's quite considerable in the overall scope of healthcare. About 1 out of 3 individuals suffer neck pain at some point during the year, and when I saw these numbers, I was very surprised by them in the sense that it is really a significant issue of significant volumes. So together with low back pain, it is one of the costliest, or it is the costliest indication. And that means more costly than diabetes, more costly than stroke, more costly than other musculoskeletal indications. And in the United States alone, we're talking about 134 billion spent on low back pain and neck pain combined. And then obviously, and you guys are very well aware of that, neck pain is a chronic issue for most. So it's not such that you treat it and it's gone forever. It's very likely to come back. And then in particular, when we look at whiplash-associated disorder, there we're looking at actually quite an impressive number as well, considering that 3 out of 1,000 per population suffer a whiplash-associated disorder on an annual basis here in Iceland. So we have about 1,100 reported cases per year. And Iceland is in that sense no different from the typical Western world. In the United States, we see at 3 to 3.5 per 1,000, and in the Western European countries, we see the same number as well. So that's considerable. 37% of those cases result in chronic neck pain as well. So that's up to 370, 400 people per year that join the group of chronic neck pain patients. Obviously, and these are maybe factors that we don't consider as much, even though it's quite a bit talked about as well. The text neck, different factors that are supporting and maintaining that type of chronic neck issue is just the use of our technology, the way we behave, the positions we find ourselves in during the day-to-day job, and etc. So important to have a way to treat that problem. And the problem is pain and stiffness in most cases, so we have to reduce the pain and stiffness. Range of motion is often reduced, so therefore we need to look at how we can improve the head and neck range of motion. And like Chris, I think, elaborated very clearly, I mean, we have the senses of our body primarily located in the head, so we're considerably impaired if that mobility of the cervical spine is impaired. Weakness of the musculature, therefore we need to strengthen that musculature, but we also have to strengthen the right musculature, so that's an important aspect. The neuromuscular control, basically that proprioceptive control over neck and head is important, and we have to regain that. And then obviously there's the vicious circle, the self-sustaining issue. We need to develop strategies to prevent those from reoccurring. And the way we at NeckGear have attempted to do this well is by bringing new innovative technology to market. And when we look at this short video here, we will see basically an overview of all the tests that can be done with the device. And it starts off with a very simple range of motion test, which you see here demonstrated with maximal flexion. You can see the cursor move on the screen. We have rotation to the left. We have the rotation in all directions, and then there's a lateral bending. So basically flexion extension, rotation left and right, and lateral bending left and right is just range of motion of the cervical spine. Then more particularly trying to isolate the rotation in C1, C2, upper cervical spine. Patient gets the head into full flexion and then tries to rotate in both directions. And we're basically registering that visually on the graph, and we're also registering that in terms of data. The third one is range of motion per quarter. So here you see a beautiful butterfly. People are following the line and trying to draw the trajectory. And this for all four movement quadrants of the cervical spine. So upper right, upper left, lower left, and lower right. That's the range of motion. Then we're on to more coordinative tests, proprioceptive tests. So here you see the butterfly test, where the patient is attempting, the cross is the patient's sensor on the head. The little ball is the target, trying to follow that target as well as possible. And with that, basically drawing a trajectory. Then we have the head neck relocation test, a test that Chris went through in great detail last week, again, to establish the coordination of the head and neck and the ability to position the head in 3D space. So those are the tests as they're implemented. The head and neck relocation test, there's tools of it, but we have full range of motion, upper spine and complete spine. We have isolated range of motion of the upper spine. We have the range of motion in the four quarters, the butterfly test, and then 3 types of head neck repositioning tests as well. Then over to the treatment video. So here we have, and this is what Chris refers to as the impairment-based treatment. So we're going to identify where the patient has functional challenges, and we're going to use those areas of weakness. We're going to train the patient on that. And that's exactly what the NeckCare and NeckSmart technology is based on. It is providing exercises that can overcome or train the areas where patients perform weaker or where limitations are seen. So there's a full program for butterfly training where you will choose the level of progression, easy, medium, difficult. You can select pattern size. The bigger the size of the pattern, the more range of motion you're going to try, which makes it more challenging. But on the other hand, you're reducing the sharpness of the bend. So that might be something that a patient is then better off with. The speed at which the little ball is moving can be adjusted as well. Target size can be smaller or bigger. And then you can choose, and this is important, which quadrant do you want to train? And then whether you want to see the path or not. And I think these are all very important aspects, because essentially what you're trying to do, and we referred to this already, is you're trying to individualize the training. For patient A, you might want to go with a smaller range of motion because they're early on. They seem to have greater limitation in range of motion movement. You might want to go a little bit slower. So you're going to progress this as the patient progresses in their training, in their treatment, and you're going to basically adapt it up until the point where they become experts at the more challenging levels of the device. Then we have a second exercise, which is the head neck relocation training. So in this case, similar type setup where we're choosing between different levels of difficulties. We're choosing whether we want to go from right to left or left to right, whether we're bending forward or backwards. And Chris made it very clear. You have to train in the areas where there's weakness. Don't try to overbother those areas that are fine. And then the exercise is done. And this is where the therapist starts deciding whether you want to make it more difficult, like in this case where the patient is seated on a ball, or potentially standing up straight as well. So you can adjust the training and make it more difficult as the patient improves and challenge their coordination more depending on their progress. This is the positioning in different degrees of flexion, a more challenging test where now the patient is turning 45 degrees. So there's different varieties on the tests, all with the same intent. That is to train those deep intrinsic muscles of the neck to try to regain the coordination that was lost. Another test is implemented as well, again about positioning. You start within the star, the arrow tells you where to move, and the patient is then aiming for a target which is non-visible that becomes visible later on. So I went through them really fast simply because we don't have the time to go into them in great detail, but at least you get an overview of all the assessment testing that is possible and then all the exercises that can be done as well. So from butterfly treatment to head neck relocation training to the head neck set to point training, different ways to pursue improvement with your patient. Then we have the telemedicine part, and we've referred to this already. So this is something that in essence, we have it ready. We're in the finalizing stages of development here, where we're trying to add that one aspect into the typical treatment, where we have the assessment, we have in-clinic treatment. We want to emphasize more the home treatment as well. And I think in the time that we're in today, as physical therapists, we probably would wish that there were more home therapy solutions or modules available, given the fact that we can't see all of our patients today. So it's very likely that some of them that have problems with their shoulders or neck or spine, that they will be coming back in worse condition as when the quarantining started and the isolation started. So we want to try to keep that circle of events a positive one, and through home therapy, try to use the time wisely in between two clinic treatments and try to gain more progress. You could look at it as the 2 steps forward, 1 step back. And we want to try to make every day count as a step forward, trying to avoid that when the patient's at home, they are not getting that forward progression. So basically the benefits are increased efficiency of training. Obviously, we have to tailor the training and individualize it to the patient's needs and their abilities. Can't overdo it, but we have a good opportunity here to keep them mobile on a day-to-day basis. We can actually verify the patient's compliance as well. And I think that is something that is important. Patients need to be motivated to do their home care. And then the treatment continuity. When people go on a holiday, in the case of an epidemic, which we find ourselves in right now, patients can continue to have their treatment. Or at least the part of the treatment that is related to training. Monitoring for critical cases. We can totally envision that over time, patients that are in critical state, if you see a patient that then goes home, is supposed to come back 2 days later, do you see how they progress when they're not in direct contact? Can the system provide you with an alert if you see that a patient is a no-show and the patient hasn't done their exercise for a few days? Maybe a trigger to contact them and verify whether everything is under good form. And then in this case, COVID-proof, right? But I have to obviously emphasize that the home therapy part that we're talking about here is only limited to what is related to training and what is related to the strengthening of the muscles. It doesn't take away the need for the mobilizations and the translations and the potential elongations and tractions and all that work that you guys put in when the patient's actually in clinic. It's just a matter of trying to move things forward when the patient is at home as well. And to an extent, avoid the kinesiophobia, which is a problem, the fear of moving that kind of kicks in, especially when a patient is in their home environment. So when we talk about an integrated solution, what we envision, and I showed this picture last Monday, is that in-clinic treatment and home activity are going to be combined. That you will have full visibility of what the patient is doing at home, how he or she is compliant to the treatment and the exercises that you're providing them. And all of it is kept within one system, which gives you the full history, the full assessment, and the progress of your patient, which is going to be a baseline for future treatment as well. So in this case, we're talking about the neck, but it is obviously, it's our vision that this can be expanded to the other joints of the body and other types of rehabilitation as well. So how does NeckCare complement your treatment? I just put down 5 key objectives that are typical objectives when you're working with people with neck pain and neck injuries. Is you want to improve the range of motion of the head and neck. You want to restore it. Well, in this case, accurately assess the range of motion and provide the exercises to improve it is what is provided within the system. Develop dynamic strengthening of the neck and its supportive musculature. In this case, we have the exercises to strengthen the intrinsic musculature, whether we're talking about the butterfly or the head neck repositioning tests, and the different variants that we've developed for the patients, they can definitely use those to achieve that goal. Regaining the proprioceptive control over the head and neck. Again, there we have the tests implemented for proprioceptive training, whether it's in clinic or at home. And then prevent the strategies to prevent pain from reoccurring. And again, here, kinesiophobia. When somebody's neck hurts, people are aware of the sensitivity of the neck and people stop moving. And it's a part of the problem, is if they were to be motivated on a day-to-day basis to at least move a certain amount of time per day, that result can actually help break that kinesiophobia and get them into a better condition. And then reduce pain and stiffness. And that obviously we only achieve that by having a stronger, more coordinated cervical spine, and therefore will be healthier and less painful. But as a standalone, the system can't provide all this. This needs to be integrated into the typical clinical pathway, the typical treatment plan that you have for your cervical spine injuries and neck pain patients in general. So alternative application, we're talking about the whiplash-associated disorder and impairment assessment. And we are aware of the fact that you are often requested for those 1,100 cases of whiplash per year to provide your impairment assessment, to do your evaluation, to assess how much impacted the patient is by her or his car accident. And in that case, we currently have an agreement in place with the 4 larger insurance carriers here in Iceland that are going to pay for the reporting done with the NeckGear system because they are looking for objective data. They want to be able to more objectively define what the impact of such an accident is, whether it's car related or a workers' comp, workers' type accident. The patient will have neck pain. In a regular situation, they'll go to the physician. In the case where it's a car accident, there's going to be a lawyer involved. They will refer patients to you either for treatment when it's physician, but the lawyer might want to have an objective assessment. And then those assessments are going to be sent back to the insurance and possibly end up with a healthcare payer as well. So this is where we believe we have a system that can more objectively show you what the impairment level of the patient is. And with that, make a rather subjective evaluation of a difficult indication, a more quantifiable one for the future. And one of the things that we're currently working on, and we have it ready in English, but it's something that we want to provide you with in Icelandic as well, is an automated report for whiplash-associated disorder. And what we're doing is basically, we're writing up the medical history, the current status of the patient, and the clinical assessment. And we're going to pull all that data out of the system. So we're going to adjust the system somewhat, where you can have checklists, where you identify what the current status of your patient is. And some of the data medical history will be entered into it as well. And then we're going to allow for clinical assessment, some of which will be through surveys, some of which will obviously be through the system. And then there will be a detailed analysis. First off, here we see it, and I know it's difficult to read for you, but the clinical assessment of the range of motion, the different tests we discussed about, we're going to make sure that the numbers are automatically put in there and you automatically get a comparison to what is considered normal, outside of the range, and how much outside of the range. We're going to make the suggestions as to how to interpret the data for you, just to make the analysis easy and to make it a quick report and an easy report for you to provide to the insurance carrier. Then there's the clinical assessment. Here we're talking about the control, the neuromuscular control, so butterfly test, and focusing on assessment interpretation. So this is the final conclusion, and then recommendations for treatment. So this is what it will look like. We're going to translate it into Icelandic. We're going to make it available. And obviously, I think that this is not going to be a closed document. This is going to be a working document where we will always be looking for input on how to improve it, such that everybody feels that this is a true representation of the situation of the patient and a good recommendation as to what the steps forward should be. Then we're looking at integrating online questionnaires as well. And in this case, we think we're going to go with about 3 to 5 questionnaires. Now, a little disclaimer there is that we need to get permission from the universities or those instances that have developed this to be able to use them. We might need to pay them some licensing fees for this, But the idea is that when you actually use these, and I'll just click on it to quickly show you, when you're online and you get the neck disability index, for instance, what you do is basically just click through it. It will explain what the test is for, and you just get to pick one of the following. So basically, I'm going to go through it quickly. Mild pain at the moment in terms of intensity. Personal care, it's painful to look after myself, and I'm slow and careful. Lifting, I can lift heavy weights, but it gives me pain. I can't read as much as I want because I have moderate pain in my neck. I'll just click through them. I won't read all of them. You're probably familiar with the test. But what we want to do is just make it easy for you. Basically hand your patient an iPad or a computer and allow them to fill this out, such that at the end of it, you will get your total score, 32% with moderate disability. And these are the accepted techniques to identify what the level of impairment is. That could be then supplementary to the testing we do in the NeckSmart software. So in conclusion, the benefits are there. This is a bit of repetition from the first presentation, but the patient will better understand the problem. They have a motivation to improve themselves and be involved from a home care perspective. For you, we hope that the objectively established baseline is going to be a good base of reference, comparing to the outcomes, and then outcome-driven and personalized care is obviously going to be a benefit as well. The physician is going to get the ability to monitor the patient as well, get the reports compared to the progress, and potentially collaborate with you on defining the next steps in the treatment pathway. And the payer, in that case, value-based healthcare. We talked about that. They want to see the data, they want to see it quantifiable, and they want to be able to approve the treatment with confidence, whether it's a whiplash case or just neck pain in general. So in conclusion, it is an assessment and a treatment tool. It's easily integrated into your practice, I believe. It's a easy to use device, lightweight, easy to manipulate. You have objective measures and personalized training can be provided from it. Patient can take the device home and continue their training at home. It's therapist friendly to collect outcomes, which is a challenge in general. The modern day technology is now integrated into your treatment plan, and all stakeholders are getting the value from it. So we believe that with a device like this, and it's a first step, obviously, looking at the cervical spine, we are now ready for the future requirements of healthcare, or a value-based healthcare, as we've been referring to before. So that is it for my first part, Maki. I suggested I turn it over to you to talk us a little bit through the technology, and then I'll be back in the end with the interpretation.
Perfect. Thank you so much for this, Kim. Right, so I'm just going to share my screen now and go a little bit through the technological aspects here when it comes to the system. Let me just share my screen here. I hope you can see this all. And right, so so in terms of the technological aspect, then at the moment I'm based here in Glasgow, just a few hundred meters from the home of this guy's house around about Glasgow University, Lord Kelvin. And this kind of is the essence of what we're trying to achieve. Basically, what he's saying here is that if you can't measure it, it's not really science. And this is the aim of NeckGear, to try to introduce these quantifiable measurements within the rehabilitation science. And at the moment, there are quite a few clinical assessment techniques out there that are kind of somewhat a bit cumbersome, using a goniometer, and Kim showed us an example where they were trying to measure wrist angles over the computer monitor. You can use a mobile phone, but that's perhaps not very practical. And in some cases, you can see that the range of motion is estimated by how many fingers you can place between the chin and the sternum. So, so as I said, what we're trying to achieve here is to standardize all these clinical tests by carrying out these measurements that we are using the NeckGear for. And and this is our sensor. This is our movement sensor, where we have our sensoring units and also the transmission to transmit the data from the sensor to the PC. We are trying to reduce the size of the sensor and making it smaller in the terms of size of a fingernail, and this will make the production easier, which means that we can start distributing these hardware systems for basically for each patient, as Kim mentioned. So in essence, what are we measuring? So the heart of the sensor is a section of accelerometers and gyroscopes. The accelerometers are measuring linear acceleration in meters per second squared, and the gyroscopes are measuring the rotational velocity. And inside the sensor, we have got a microcomputer, which essentially converts these signals into angles, joint angles. And then we've got our Bluetooth component, which transmits the data wirelessly to a PC. Now, the step of going from the acceleration data and the gyroscope data is a fairly known one, and this is a technique that was formalized by an Irish mathematician, Hamilton, which was based in Dublin. Used this algorithm called the quaternion algorithm, and this algorithm is used extensively in many different devices that you use in every day, and most prominently, obviously, the mobile phones. And when you switch your mobile phone from landscape to portrait, the phone is sensing this rotation, and also, which is why they've been used for the clinical assessment. But the sensors aren't as accurate as ours. And basically, what we've got then is a system where we have got rotation around our three axes. We've got the lateral flexion, the flexion extension, and the rotation. And this is essentially the raw data that comes out. Now, how do we know this is the correct data with the correct values? And we've gone into extensive validation work by strapping it to a robotic arm. Now, I'm not entirely sure if you can see this. Let me just go through here and just to make sure that you see the video. And here we go. Share this, and there we go. Sorry about that. I hope you can see this here. So here we've strapped this to a robotic arm, which has got an accuracy of 1/1000th of a degree. And here we are comparing the angles from the robotic arm to the measured angle of the sensor. And although it looks stationary there, then what we're doing there is that we are rotating of a 0.1 degree and checking for how stable the signal really is. Additionally, we have been using motion capture techniques here, and here we are looking into range of motion tests here by using our infrared cameras. This test was taken at Össur, the motion capture laboratory there. And there we can see, then we can actually calculate the rotation based on the location of these dots around here, and then we can compare that against the angles that we're actually measuring. So, and from the robotic arm, we're getting an accuracy which is on the order of magnitude of around 0.02 degrees. So, the scientific validation is essential for our work to be able to. We need to make sure that the degrees that we are reporting are indeed the correct degrees, and which they are. And essentially, so here we've got an example about raw data, raw signal coming out from an flexion extension test. And this here, the graph here to the right shows the rotational velocity test here that Chris mentioned a week ago, where you're measuring basically how quickly you can move the head from right to left. And here are the angles, and here is the angular velocity. Now, in regards to the setup, then our recommendation is that we place the subject around 90 centimeters from the monitor. Now, this is not a figure that is set in stone. You know, we've got this can be 100 centimeters. This is not critical because of the fact we're actually measuring the degrees. Now, referring back to the talk Chris gave last week, was that using the laser and the target on the wall, then you're quite dependent on the distance from the distance from the subject to the wall, and also as you're measuring the distance in centimeters, the target is from the bullseye. And there was mentioned that if you're within 5 centimeters, either right or left, then you're good. And if there was mentioned also that the subject was 1 meter away. So going through a bit of trigonometry, then if you take an arcus tangens of 0.05, you will indeed get an angle of 2.8 degrees, which is essentially also the what we're finding with measuring the angle directly. Okay, so the distance from the computer is tried to be around 9,200 centimeters-ish. So, but it's not a critical number. But also try to have the screen round about middle of the screen round about the eye level, so that the patient is not positioning himself in a flex position, looking down on the screen, for instance. And we would also recommend to place it in a chair with a relatively high back, because what we don't want is to be measuring any kind of trunk movement. And so we need to have a good stability there for the patient. Now, what I wanted to do now is to go quite quickly through these tests. Now, Kim obviously touched upon this, but I wanted just to show you this in real time, and how this works. So this here is the program setup, and we categorized our tests into these three categories: the proprioception, the movement sense, and the range of motion. So if we go, I'm just gonna go back. I'm gonna stop sharing here, and I'm gonna move over to the system again. So here we go. So hope you can see this. Hope you can see this okay. We're gonna go here, and so here when you log in, then you have got your patient list here, and you select your patient, and you need to then connect to the device. Now, what you need to do is to place the headgear on a level surface, on a table, and then then you need to establish the communication between the Bluetooth from the sensor to the computer itself. And here you've got a message on the screen saying you can connected to the device. You can now continue. So and placing the headgear on the head, then you are ready to start the test. And as you can see here, then I'm controlling here the green cursor, and I'm following here. The task is to follow the dot, the target. Okay, I'm just going to go, for the sake of time, I'm just going to go through one round of it and talk you through it. And as you can see here, that the target moves at a different speed. So here you can see the target is almost stationary, and this, we've seen that in some cases patients with whiplash are struggling to maintain the position. Obviously, I'm not doing so great while I'm talking and doing this, but we see that they start to shake a little bit sometimes there at that point. So well, let's just take one more round here. But I wanted to show you also is that, as you can see here, the velocity of the target here is changing. Okay, now it's Sod's law that I actually got two of the same tests coming up in the one after the other. Now there are 3 difficulty levels on this, and they come up in a random order. So having these 2 curves, the same curves coming up again, one after the other, is merely a coincidence. And but what we see here is that right. Let's just do one more here. So we see that the velocity of the target changes. Okay, and the velocity is based on the radius of curvature. So what it essentially means is that during straight segments, the target will move faster, and in bends it will slow down. And like this. Okay, I'm just going to stop this now here and and show you maybe a report here that comes out. So a report is a report is automatically generated after each test here, and you can select, for instance, all the butterfly test here, and I know that this one is mine here. So what the system is doing now is that it is basically downloading the data from our server. So yeah, one thing to mention is that the data gets sent up to a server, and then once you call for a report, then that is downloaded back onto your computer. So here you can see the trajectories, and what we're essentially measuring here is this variable here is the amplitude accuracy, which is the distance, the overall distance the subject is away from the target. And here we've got the directional accuracy, which means that it looks into the percentage time on the target that the patient is actually on the target, behind the target, or in front of the target. That's the red here, the overshoots. We measure also the smoothness of movement, and this here has been, this value here is a normalized value. So well, theoretically this is the time derivative of the acceleration, and it essentially is just measuring how much you're jerking your head while you're keeping up with the target. And you see those green areas, so these are what is to be considered a reference, normal reference values. So this is how our reports are built up. We've got numerical results, we've got the graphical results to begin with. And then moving on to the numerical results, if you feel that way inclined, if you want to have the breakdown of the numbers. And then we have got a small section of the outcome measures themselves, just a small explanation about what is what. So moving back here onto the onto our slides, then we can see here our this is the representation of the joint position error test, or head neck relocation test as we call it, and we've put this up as a bullseye here with our reference normal values for the butterfly, and additionally for the whole range of motion, which Kim mentioned earlier. We're gonna, so in the interest of time, I'll wrap up the technological aspect here, and hope I've convinced you that we have designed a very technically robust system. We are confident of the level of accuracy and the level of repeatability as well. And this has been validated against both motion capture and from a robotic arm. And when we've used our software, when we designed our software, we designed it so it would be relatively easy to use, so that it's not, you don't need to have a degree in computer science to be able to operate this. So we wanted to have this as accessible as possible. So out of those tests that we have had, we have in our system, this is a standard clinical test that you're doing in the clinic, and also touching on the remote, so we can go through the remote patient rehabilitation. So as Kim mentioned earlier, we can go, the subjects can take this home, do the exercises, and and therefore kind of continue the rehabilitation outside of the clinic. And just to leave you on the note that, you know, we take our scientific background very seriously, so we're always in the researching and continuing to publish papers on the matter. On this note, Kim, I'll hand back over to you, and if you want to go a little bit through the kind of clinical interpretation.
Thank you, Magnus. Can you hear me again?
Hear you loud and clear.
Okay. So obviously it's great to collect data, and as every other branch of medicine, the challenge is, what do we do with the data? How do we interpret it? How is it useful? And how do we practically apply it to our treatment plans? And with the next chapter, we want to give you a little bit of an insight. And to be honest with you, it's more like a tip of the iceberg, simply because it takes time to go through it in more detail. But we do want to give you a bit of an insight as to what is it that the system is providing. And when we look at it, there's 6 major testing capabilities. The range of motion of the upper cervical spine is 1, just the rotational ability of the neck in full flexion, C1, C2. Then we have the cervical range of motion, the whole cervical spine, combined maximum range of motion of the head in the cervical region. Then we have the cervical range of motion measured in the quarters. We talked about that, basically looking at cervical mobility and movements in all 4 movement quadrants. We have the butterfly test for proprioceptive ability of the patient to control the movement. We have the head-neck relocation test, the natural head posture, basically looking at the integrity of the cervical spine and to look at the joint positioning sense of the patient. And then the set points in range, where we're specifically looking at how they're positioning their head in 3D space. So I'm going to take a few of those and give you a little bit more insight as to how we see this practically applied within physical therapy. Range of motion test, considered to be maybe the easiest one, where we have cervical flexion rotation test. Basically, patient is bending their head as far as possible and is then trying to execute the rotation, measuring C1, C2 rotation. And diagnostics accuracy, sensitivity, and specificity of this type of test is very high. And we're not talking about our design here, we're talking about just this test in general. This test is considered to be a reliable test, even when executed manually. Obviously, the readings that you get out of it are supplement. Then we know that 50% of rotation comes from the cervical spine, or about 45 degrees in both directions of the 90 degrees of rotation that is possible, will be provided in that upper part of the cervical spine, C1, C2. And when you fully flex it, you're isolating that moment, resulting in about 44 degrees motion possibility and rotation to both sides. So when you look at the picture below, they come straight from the reports that Magnus was referring to. This is the degree of flexion. So basically, this is the axis in which flexion is executed. And then you see rotation to both sides. And in this case, patient finds himself within the reference values. So here we're talking about that value of 40 to about 50 degrees is the range of motion that is indicated. The dots fall straight within. So it's a very easy, quick assessment as to where the patient finds himself. This is based upon 6 measurements. And this is where you get the repeatability of the measures, which is interesting in the case where you would see a deterioration over time. For some patients, it could be causing fatigue to execute these tests. So it's interesting, and it's important to know whether what you're measuring is consistent or whether certain peaks are measured. Now, why is the range of motion important? Often cases, you know, people are suffering headaches, and it's important to be able to differentiate between headaches that are related to the C1, C2 function, or headaches that have a different type of cause, potentially migraines. And what we're seeing is that those patients that are in fact having C1, C2 dysfunction, they have an average of 17 degrees less rotation. And on the next slide, we can see that there are actually studies that have investigated how can you connect the mobility of your cervical spine to whether you have a cervicogenic headache, so the headache that is related or that is caused by the cervical spine mobility issues, or whether you have a migraine. And it shows that those test results are 100% in terms of sensitivity, 94% in specificity. So basically means that it's very easy to differentiate between a headache caused by the upper spine or not. But what is the degrees in which we say, here we're still talking about a potential cervicogenic versus this is where it is just migraine? Well, that is the typical, from a 25 degrees limitation, we believe there's a clear indication that it is cervicogenic related. When you're talking about migraines, they will still get up to the 40, 44 degrees that is considered to be normal. Multiple headache forms, they typically tend to be a little bit restricted, but nowhere near where you would see the restriction if it is typically or true cervicogenic issues. So an interesting test, an easy test to see, because physical therapy has shown to have only positive effect when it is cervicogenic. Otherwise, we have challenges in treating migraines. So that's just an important fact. Then when it comes to the full cervical spine, here we're basically measuring, again, as you can see here, the maximum rotation. In this case, we're approaching the 90 degrees on both sides, where in this case, we have somebody that is a little bit hyperflexible, turning right, and nicely within the range on the left-hand side, where forward bending is maybe a little bit limited in this case. But we also see, again, the consistency between the 6 measurements. So 80 to 90 degrees of flexion is normal, 70 degrees of extension, backward bending is normal, 20 to 45 degrees of lateral flexion, and then up to 90 degrees of rotation in both sides, since we're not isolating it at the moment. Then we get to the 4 quarters test, and this is where I think it gets quite interesting in identifying which part of the cervical spine is actually limited or is affected. In the example that you see here, basically, patient is asked to track the line, forming this entire butterfly profile. And whilst they're doing that, the way they are doing it, if they're nicely following the line, they're covering the total surface. And this surface is measured. So if they, in this case, you see here one measurement where patient was not able to follow the full line, the surface is minimal. Therefore, we see a number here, 0.87. It was the first measurement, possibly related to the fact that the patient didn't really understand what was needed to do. We see that it normalizes after a few measurements. So in this case, we're seeing that the indexes that are calculated, they basically tell you that the patient, on a mean average way, they're able to complete the full range of motion quadrants. And when you then interpret that further, I mean, total areas covered, you have a score of 1. Lower the area covered, the lower the index, the higher the level of impairment is going to be. So in this case, we consider the 0.87 to be an anomaly, and we're looking for, we are in general looking at a healthy subject. Now, this example here is taken from a 44-year-old male that has suffered a severe whiplash-associated disorder. So here we see that we've got a reduction of range of motion in all 4 quadrants, a significant reduction. We also see that based upon the different tests, there's a high level of discrepancy. There's a high level of variability. And that's something that we typically see, is that for people that are suffering whiplash-associated disorder, fatigue will kick in, and it's going to affect their ability to reproduce these measurements consistently. This then in strong contrast to someone who has an unidentified neck pain issue. So here we see someone that has performed the range of motion test. You see that generally speaking, this person is able to cover the range of motion in 4 quarters. However, something is indicating that in maximum range of motion in the lower left quadrant, there's a peak there. There's a motion that you wouldn't expect, that shouldn't be there. This could be an anomaly that is referring to a painful sensation or something that triggers him to have this type of anomaly. So in this case, for this particular patient, we'd be looking at treating the flexibility, mobility of the left lower quadrant. And we talked about outcomes the first webinar last week. And I think this one is a really nice picture that shows how important, or how outcomes can validate the effect of just one single treatment. So what we have here is 20 patients that were that joined into a test where they measured the quadrant movement prior to treatment. And then same scale, no cheating here. They measured them again after one single treatment session of mobilization, tractions, the typical treatment, some overall treatment for cervical spine. And we see that the increase in range of motion is quite dramatic and is very visual as well. So what this shows is obviously that from a value-based healthcare perspective, the value of that one treatment is obvious. And we can see that within the numbers that are represented here. Tracking this over time, it would be very interesting to see if we sent this patient home and we allow them to do exercising at home and they maintain 3, 4, 5 days between different treatments, they maintain that mobility, whether they come back and they have a positive remaining effect prior to treatment, and whether we can see a difference between a person that goes home and doesn't necessarily do anything coming back 4 or 5 days later. So that's interesting research that we're looking to evaluate further as well. But to proving the effect of your treatment, this is the picture, I guess, speaks louder than words. Then we get to the butterfly test. And in this case, like Maki explained, there's 3 patterns. There's easy, medium, and difficult, with variations on acceleration of the target. And we're measuring basically how well the patient performs at keeping on the line, basically tracking the target accurately. And the amplitude accuracy in this case is basically measuring the average deviation between the target and the cursor. So deviation meaning you can go left of the line, you can go right of the line, you can run a little bit ahead of the target, a little behind the target, all of that averaged out. For the easy target, and these are my measurements, you have a measurement of 1.2 millimeters of amplitude accuracy, which falls nicely within the normal reference values. As it gets more difficult, we see that the scale actually changes. This is a maximum of 3, 5, a maximum of 10. And we see that, you know, as a healthy asymptomatic person, I managed to keep the result within the normal expected value. When you look at the directional accuracy, so here we're basically saying, am I on the target, am I overshooting, or am I running behind? Am I delayed and I'm trying to catch up? So don't compare my numbers to Magnus's earlier, because mine is in the 50s. I think Magnus almost touched 70. I guess practice does make perfect. But it basically goes to show that this on target is the key number to evaluate. The ability to stay within target. And I'll show you an example of a whiplash case in the next slide that clearly shows how impaired that particular ability is. Then another number was the smoothness. Maggie already touched upon it. Basically the acceleration of the head while performing the butterfly test. The lower the value, the smoother the movement. The smoother the movement, the better control you have over your neck muscles. It's that simple. So that coordination, the proprioceptive control, defines how smooth you're going to be able to track the value. So enough about normal people's evaluation. When we take a look at the butterfly test for a 53-year-old female that has suffered a quite severe whiplash-associated disorder, this is the typical picture that we get. So takeaways from that picture are, first off, that she does have a reasonable ability to track the easy pattern. And I think that's an important thing to know, because when we're evaluating and assessing whiplash, this is something we expect to see. If patients are all over the place here, something else is going on. That's not the typical type behavior that we're expecting. Medium pattern, it gets progressively more difficult for this patient to follow the line. And then difficult pattern, she's starting to move more all over the place. And you're seeing that aggressiveness in the edging of the movement, the jerking, is represented within the direction of the lines as well. So when we take a look at her amplitude accuracy, we see that here she's at the top of the scale. Here we still see a little bit of it, but basically she's exceeding the 5 millimeters of deviation. And then in the difficult pattern, she's around 7.5, 8 millimeters of deviation. So she's outside of the normal range. However, and we'll see that in the next slide, she's inside a very typical range associated with the whiplash associated disorder. So it's important to consider that as well, because we want to evaluate the sincerity of the claim as well. We want to evaluate whether we can show whether it is in fact whiplash or not. And then we have the tracking. Remember, I was in the high 50s, Maki was close to 70, and here we have a person that only manages to stay on target for 19.4%. Again, a typical type of result for a whiplash-related injury. And then the jerk factor, the smoothness index, this person here, this lady scored at 3.99. So that is considerably higher. Poor smoothness, more jerking of the neck basically refers to poor coordination. So the poor coordination, this is where we would typically say, okay, let's give her, and this is actually a process that we're into, we're providing this lady with the device to train at home, now specifically because she's a severe case, she's in pain, she's struggling considerably. We've provided her with the Neck Smart solution so she can train at home. We're going to track her. We're going to see whether this alone, granted the fact that she can't see her physical therapy today, is going to help her reduce the pain and improve her coordination somewhat. And then last but not least, for this patient, we also performed the full range of motion test in all directions. And you see that she's reduced, she's limited in every single direction. You can tell backward bending, strands here, just short of normal. Same with the rotation, same with lateral bending, and the same with the flexion. Now, interestingly enough, she doesn't have a quadrant or a particular side that is worse, much worse than. So she's basically limited in all directions. And that's also something that is rather typical because the superficial muscles tend to contract and tend to reduce overall range of motion for the whiplash patient. So I mentioned it before, the reliability and the usability of the data to evaluate the whiplash result is interesting. We look at the medium pattern here of the lady measured in the previous slide. Remember, in this particular measurement, she was just out of the range, meaning that she's 5.5 millimeters on average off track as she's trying to track the device. Now this here comes out of a study that has been performed where we're comparing the regular measurements of people that are asymptomatic. We're measuring the whiplash patients, and then we're basically telling people to fake a whiplash type behavior. And what we see there is that 50% of the patients find themselves within the box. 25% find themselves within this range, so below the box, and 25% about roughly find themselves in this part above. And then there's some outliers. So what we see is that for this medium difficulty pattern, this particular patient scores of 5.5 millimeters, which would find itself here at the outlier range for the whiplash population. Now, she's still below where the majority of people that would try to fake a whiplash will find themselves, and she's largely above where just regular asymptomatic measurements are. So this is something that has been studied. The reference of the study is below it, where the study was specifically focusing on identifying or the ability to differentiate between asymptomatic, potential non-sincere whiplash claims and then the sincere whiplash claims. And obviously this can go in both directions. You could have an insurance that is doubting whether a patient has a whiplash, but the numbers show very clearly that yes, this patient has the typical characteristics of a whiplash patient, and thereby we can support it objectively, which is great. Other way around obviously is a possibility as well, that there are doubts about the sincerity of the claim and that we're just not finding those types of results within our results. And by that, there might be an indication that there's some insincerity related to the claim. Now, bottom line is this is a one test, and then there's obviously other tests that need to be done. There's the surveys that need to be done as well. So it's one part in the decision-making for the insurance company, for the lawyers to discuss how they're going to move forward. But the good thing is this is an objective measurement, and that's what it is all about. So the ability to define whether or not it's a true positive rate, so somebody has a whiplash, is close to 90%, and that is considered to be very high within the medical environment. So definitely a very usable tool in that sense. And then Basically, the outcome of the study was that the system, the method can be used to evaluate validity of whiplash claims. And more importantly, and that's what we are obviously all looking for, is we can both assess it, but then we can also provide it as a treatment method. Because over time, as the patient improves their intrinsic cervical muscles, they will be able to track this pattern more correctly and will eventually have a general more efficient behavior of their musculature around the neck, and that should reflect in an overall quality of life gain in daily life. So the head neck relocation test, just very brief, because we're kind of running out of time a little bit, but also because we can't teach everything in just this one session. But here we see that same test performed by a person that has whiplash. And we're basically seeing here a number of turning left 2.28. And as Magnus was explaining, this is about the degrees of deviation, and this is the accumulated degree. So whether you're turning left and you're overshooting to the right, or whether you're stopping too soon, they're both added on to each other. And this is where the science tells us that if you are in a if you're in a range that is between 0 to 2 and 2.6 degrees, there's no real impairment. There's no need to train this level of joint positioning sense or proprioceptive control of the cervical spine. If you're between 2.7 and 6.5, there might be moderate impairment, so then it is important to take a look at it. If you're severely impaired, then obviously this is going to be one of the key items, the key focuses of the treatment. So this is where the NeckSmart system comes into play. This is where you're going to be able to train your patient's intrinsic muscles to improve that neuromuscular control of the cervical spine. So in conclusion, we see there's a ton of different measurements that we're taking, from range of motion to butterfly test to the head relocation test, different tests that all serve as a building block to identifying and assessing the actual indication of the patient. And obviously, where the weaknesses are, we're talking about the impairment-based treatment. We're going to identify our therapy, we're going to individualize it, and we're going to train the patient right there where he or she needs it most. So in conclusion, the assessment of the severity of the impairment is important. We need to know what we're dealing with. We can definitely, the testing will indicate us where the limitations are most prevalent, so where we should focus, prioritize. It can help us exclude certain indications based upon the scientific data that is there, whether we're dealing with an actual case of whiplash with specific training requirements, or whether we're dealing with a different type of neck injury. Setting the clinical base of reference to track the progress of the patient is very important as well. And then outcome-based clinical practice, basically setting ourselves up for the future. Value-based healthcare is what it's about, and that's what the future will require from us. So with this, we have a tool, a first tool in our bag that can help us identify and quantify exactly what we're dealing with, how the patient is doing, and how we can potentially improve their situation through in-clinic therapy as well as the home therapy. So that's just basically a snapshot of what the system is able to do, how you can assess, how you can treat, and how it all kind of builds together and links together within your clinical practice. So with that, I think we can maybe shortly open up for some questions, if there are any. And I know this has been a long session, but Maki, did you receive any questions through the community?
Yes, we have a couple of questions here. One question here was, why not practice the movements that are in normal test results? Can a person not get accurate by practicing? Maybe I can start answering that. Yes, the answer is yes, that then you can, as Kim mentioned, then practice does make perfect. Now, we need to discriminate here a little bit against the test trajectories and the rehab trajectories. These are not the same. And when you're carrying out the clinical assessment, so these trajectories that were shown there, the easy, medium, and the difficult, they are fixed. Okay, so the patient would not be seeing those trajectories more than 3-4 times, and that's not enough to learn into how they move. And additionally, they come up in a random order. I realize that perhaps my values are quite a bit skewed, as I've been doing this for testing purposes. I've taken numerous of these tests, and then yes, you can improve by practicing, but it's not enough, the repeatability that for the patients to be able to shall we say, map out these assessment trajectories.
If I can add to that, Maki, I think it's quite straightforward. If you get better and you're able to perform the test better, that just basically means that your intrinsic muscles are firing better, that your proprioception has improved. So I think, in essence, if a person actually is learning, that basically means the therapy is working. If you twisted your ankle and you're in the early stages and your proprioception is not okay, you're not going to be able to do the more difficult exercise. You're not going to be able to fake that you can do it, because the muscles aren't going to be capable. So I think, in essence, it is about practice. It is about training and therapy, and that's the bottom line. Is by doing it more, you're likely to improve.
Perfect. We've got another question here. Are there any formal studies on the way to see with EMG measurements what muscles are activated during the butterfly test? Again, maybe if I can start answering that, then yes, that's on the long to-do list. I guess the problem, well, not the problem, well, the EMG studies that have been carried out, we've done some kind of pilot testing, and what we're seeing is now for the patient cohort is that the superficial muscle, the big muscles, sternocleido and etc., they kind of take over. Now the muscles that are primarily controlling the movement are the deep muscles. So you would need a needle EMG. And if memory serves, then I believe there is a group in Vancouver that has looked into measuring EMG for the deep neck flexors. But no, an EMG study would be a full-on EMG study would be very, very interesting. Another question here is the NeckCARE system already on the market? Well, yes, and but also is that another maybe one of the objective with these webinars is to have the dialogue with the clinicians, and we certainly want to develop the system further with the clinicians.
Yep. Yeah. So the answer is yes, the system is available, and I think this for us has been an interesting way of presenting it to you, reaching out to all of you to let you know that it is available. And in the weeks that are following now, we would love to follow up with you and get your, maybe in a smaller group or one-on-one, your feedback as to how you perceive this to bring value to your clinical care, and to start rolling out the system, because obviously the power is in the data. We know what to do with the data. And if we can all start measuring in a consistent manner, then I think we can put Iceland on the map as a country where neck pain is universally and uniformly treated, which is quite unprecedented, I would say, worldwide. And possibly we can show some great results to support that this approach is the right one for the future.
Indeed. Another question here is this an Icelandic discovery? And the short answer to that is yes. The butterfly test was developed from a PhD thesis from an Icelandic physiotherapist called Dr. Eyþór Kristjánsson, who came up with the idea, and shall we say that the system has gone through many different changes. We've changed the software, we changed the hardware, etc. But yeah, in essence, then this is an Icelandic innovation.
Yep, I was most impressed with the fact that there's 20 years of research behind it. And for some, it might mean, wow, 20 years, that's a whole lot of years to come to a good conclusion. But I think it's important to realize that the technology that we have today wasn't there 2-3 years ago. Mm-hmm. And I think now we're at the point where we have the right technology, we have validated and proven methods. And I believe that that combination is the starting point, if anything, the milestone that we had to cross to be able to say, we're ready, let's go, let's take this forward.
Mm-hmm. Indeed. And what's been very enjoyable on this journey is also to liaise with physiotherapists abroad. We have a good connection to a very, very good guy in Germany, and a rehabilitation clinic there. There's an input from them, taking valuable measurements as well. Got a connection in Slovenia. There's a master student in Melbourne in Australia, which is looking into using the system for his thesis. Yeah, it's been really enjoyable to liaise with the international.
Absolutely. Sweden, Belgium. We're trying to put the United States on the map as well. So it's interesting times for sure.
Indeed. One question here, is it available, and how to get information on costs and start working today? I think what we should do is that if people are interested to get a more kind of in-depth tuition, to get in touch with us privately, and we'll set up a more kind of one-to-one meeting.
Yes. And I mean, we will send you guys, all the participants and all of those that weren't able to participate, we're going to send you an updated brochure, which basically talks you through the research behind it in a very light and digestible manner, the system, the setup, and you'll find your way through it quite easily, especially if you've been able to attend the webinar. And absolutely, we're here in the next few weeks to follow up with you and talk you through the practicalities. Because a first step that everybody's going to have to take is certification. We want to certify anyone and everyone that uses the system to make sure that we're getting the right readings, the right measurements, and to make sure that the valuable data that you collect is reliable as well. But that's going to be the next few weeks for us, and hopefully for you as well. So let's use the downtime, I would say. The fact that we have less patients to attend to might be the right time to learn something new and be ready when we're ready to implement it.
Absolutely. Now, as we stated in our first meeting last week, was that we were going to record this, and I don't know if you see this. I've just in the chat, I've posted a link to everyone where you can access the first two webinars, and we'll of course put these put this last lecture on there as well.
I think we can probably round it up here. I would like to ask Thorstein, the CEO of the company and the person that has been carrying the project forward for the last few years, to basically close with a couple of words and also a bit of a vision for the future, because there definitely is a vision, Thorstein.
Hope you can hear me, guys. Thanks for attending the webinar. I believe I have a slide somewhere there, so hang on. Okay, guys, as you might well know, I'm responsible for the business part of the equation. So we leave the science to Dr. Magnus and Kim DeRoy. I just want to point out to you that it's actually on the conveyor belt right now. So we've already designed it. So what you see there in front of you is to the right is the new movement sensors. It's a tiny little thing, size of a fingernail, just like Magnus said, and the potentials are tremendous, not only for measuring cervical movements, but also the shoulders, the knee, and so on and so on. So a lot of potential revenue streams for the physiotherapy industry. We are collaborating with the University of Reykjavik with measuring athletes, elite athletes, and this could actually be the physio tool to engage with the sports enthusiasts, or to follow up on their obesity patients or heart patients, for example. So it basically gives an indication as to whether the patient is moving or not, how he is moving, the temperature, the humidity out there, and so many other things. So get ready for this. This will be introduced to you guys formally in June, July. So I just wanted to point that out to you. There are a lot of very exciting opportunities coming your way. So having said that, I just want to say thank you so much for attending. Bye-bye.
And thank you so much for this, Thorsteinn. And I think that on that note, I think we can just conclude our 3-series webinar. And again, thank you for listening and your input. Perfect. Cheers.
Thanks, everyone.
Thank you.
Bye-bye.
Bye.